Hey, everybody. Good afternoon. My name is Solomon Bihar. I am a pediatric ER doctor at Long Beach Memorial and Miller Children's Hospital. I have the privilege of hosting a podcast called Pediatric Reviews and Perspectives, otherwise known as Peds RAP. We've been doing this for like 9 years, covering all of pediatrics, general pediatrics, inpatient, outpatient, the latest literature. One of my favorite segments, that's a recurring segment that we do, is something called Morning Report. For those of us who have been out a few years, you guys remember when you were residents, it was that really fantastic time of learning when everything was so concentrated and you could spout off things like confidently, like, oh yeah, it could be Legionella, it could be histiocytosis. And then you go into practice, you forget about all those exotic fun diagnoses. We have a really wonderful panel here today featuring our UCLA current pediatric chief residents. We've got Ozioma Obiwuru, Jennifer Bailey, Megan McKittrick, and our pediatric GI specialist, also from UCLA, Alvin Chan. They're gonna tell you guys about a really, really interesting case. So enjoy this. This is going to be on part of the podcast, and this is our very first live event. We've never done a live event before, so really exciting, and I'm really this is an excellent, excellent group of doctors. I've worked with every single one of them, and they are awesome, and you're going to learn a lot from them. After their segment, we're going to come back for a second segment with some of the AAP Chapter 2 leadership to talk about why you should join your local AAP chapter, which all of you already know why you should do it, but we're going to tell the rest of the world. All right, thanks you guys, and enjoy.
Thank you so much for that introduction, Dr. Bihar. So Ozi and I will start off. We're going to talk about a case of a patient who presented to UCLA during the course of our residency. So Ozi, can you tell us a little bit about this patient and how she initially presented to care?
Yeah, sure. So this was one of the most memorable cases from my time in residency. We have a 15-month-old, previously healthy, fully immunized girl who presented to her outpatient pediatrician's office at UCLA with a day of vomiting, diarrhea, low appetite, low energy. Her pediatrician does a thorough history and physical and diagnoses her with the presumed viral gastroenteritis. So he and the family discussed supportive care measures, and the patient sent home. We picked the case up again about a month later, and now she's back. Parents are saying, you know what, this fatigue is really not getting any better. And we've also noticed some strange changes in her development. So we're picturing a 15-month-old, she's active, she's bouncing off the walls, talking nonstop, really asserting her independence, and all of that's gone away. So she's not talking anymore. She needs help eating, getting dressed. She refuses to stand, to walk, or to run. And this was all pretty concerning.
Yeah, this is a really interesting case, I think, just because the initial presentation seemed like a viral gastroenteritis, which something for general pediatricians is something very common in the outpatient setting. But I think what made this case stand out is that really after that, in the next month, her case kind of took a turn. So I know you touched on a lot that happened to her before she came back to the pediatrician's office. Can you talk a little bit more about her growth and how that changed?
Yeah, so her pediatrician, very, very astute, as we should always do, he pulls up her growth charts. And so if you move on to the next slide, as y'all can see, there's a pattern of weight loss and also of decreased growth velocity that spanned the course of four months. And so her weight crossed multiple percentiles. She started off around the 90th percentile, and by the time she was at this visit, she's down to the 43rd percentile. The same trend was seen in her height. She started off around the 75th percentile, and by the time of this visit was down to the 25th. A lot of red flags.
Yeah, I think this is all really incredibly striking, especially when you look at it here in the visual representation. So given all of that, I think that we were all very acutely concerned for this patient, and so she was referred for inpatient admission to expedite her workup. Can you talk about how she initially presented to our inpatient team?
Yeah, we were pretty concerned, sent the family straight to the emergency room. And so we start with our doorway assessment, as we often do with our pediatric patients. Thin child, she looked pretty pale, and her posture was quite interesting. So she's like slumped over in her caregiver's lap, which seemed a bit strange. Her vitals, though, were normal. Heart and lungs were normal as well. And then we moved down to her belly exam, which was soft, non-tender, but slightly distended per her parents compared to her baseline. I think most striking was her neuro exam. She was able to follow some commands, but really would not engage with any examiners. We noticed diffuse hypotonia. So this is a 15-month-old who had head lag, which is completely unexpected. She had slipped through on a vertical suspension test as well. We placed her prone, and she wasn't able to push up on her own. Reassuringly, her sensation and her deep tendon reflexes were intact, but even despite our best efforts, we could not get her to stand, to pull to stand. So it was all quite strange.
Yeah, I think all of that just sounds incredibly concerning, especially with the history that the parents provided. So thinking about that physical exam, especially the neurologic portion, and then the parents' concern for developmental regression, I can imagine this is a pretty broad differential. So what were some things that you all were thinking about at the time?
Yeah, so we're thinking big picture. We have a 15-month-old who's presenting with what seems to be developmental regression, and her exam is really notable for hypotonia. So we started off with, what are those diagnoses we absolutely do not want to miss? So thinking about infectious causes, could this be something acute on chronic? Thinking, could this be a CNS autoimmune or inflammatory condition? Things like encephalopathy, meningitis. And then one thing we absolutely did not want to miss in this 15-month-old with such an acute on chronic change in her neurostatus was maybe a space-occupying lesion, something causing increased intracranial pressure, maybe a brain mass or tumor. We wanted to make sure we didn't miss that as well.
Yeah, that all definitely makes sense. And I think one thing for us to think about as well, if we're still thinking about hypotonia, would be celiac disease. And then I know this patient had hypotonia, but if we take a step back for a moment and think about if she did not have hypotonia, the differential diagnosis becomes even broader. And I think there's some things that we still want to think about. So staying in our GI bucket for a second, we can think a little bit about nutrient deficiencies. So like B12, like copper, for example. We can also think about like a poisoning and intoxication with a substance like lead. And given our patient is 15 months, that's something that we definitely want to consider and make sure is still on our differential. But pivoting a little bit, we think about other causes like genetics causes. So in that bucket, some things that I think we really want to consider would be Rett syndrome, which of course this patient is female, she would fit that, or an inborn error of metabolism. So again, this patient is 15 months, so usually those will present a bit earlier, but we still just want to keep that on our differential for this patient at this time. And we can also even think about epilepsy. And then the last thing I think for patients, all of our pediatric patients really thinking about advocating for them would be like a psychological trauma that could lead to this developmental regression. So suffice to say, this is a very broad differential. So what did you and the team decide to do next to narrow it down?
Yeah, that was a great summary and all of the things that we thought about with this case. So first, in terms of our workup, we wanted to think, again, what are those diagnoses we absolutely do not want to miss? So we got an MRI of her brain and spine, and reassuringly, those were normal. She also got a lumbar puncture while she was admitted. Her CSF studies, including a meningitis encephalitis panel, also came back normal. We sent off a slew, as you can see behind me, of vitamin and nutrient studies, some of which came back lower than expected. And then we also sent off a complete metabolic panel, and that was notable for pretty low serum albumin. So now our wheels are turning. We're thinking, are we dealing with a malabsorption picture? Could this be some sort of protein-losing enteropathy? So we got in touch with our GI colleagues who recommended a few more studies. We got a fecal calprotectin, a fecal alpha-1 antitrypsin level. We also got a tissue transglutaminase IgA level, as well as an endomesial IgA level. All of those came back elevated, which raised the suspicion for possible celiac disease.
Wow, that's definitely not something that at the beginning of this case I was thinking about. I think I can speak for a lot of us. So given that you're thinking celiac disease, was there anything else that you all decided to do in conjunction with your GI colleagues to help narrow down if this was celiac disease and kind of confirm the diagnosis for us?
Yeah, that's a good question. I did not do, I am not a GI specialist, but our GI colleagues did an upper endoscopy. And if you go to the next slide, I think we have some pictures of the findings. So they saw flattened villi as well as scalloping in those duodenal folds. Those are all pretty hallmark on endoscopy for celiac disease. They then sent off some biopsies, which confirmed the diagnosis.
Okay, so this is definitely celiac disease and definitely something that I think is pretty unique given how this patient initially presented to care. So given that, what did you all decide to do next for this patient?
Yeah, I think this totally changed my practice. And I think maybe not something that was on my differential before, but anytime I'm seeing any weird developmental things, I'm always thinking about possible nutrient deficiencies and malabsorption. This patient actually was made NPO during part of her admission for all of these studies. And we noticed during that NPO time that her symptoms sort of got better. Now knowing that that's celiac disease, it made a lot of sense. We put her on a gluten-free diet. All of her symptoms resolved totally back to her neural baseline.
That's actually really incredible. And I think for all of us, definitely some food for thought going forward. So now I just wanted to pass it along to Dr. Megan McKittrick and Dr. Alvin Chan to talk to us a little bit more about celiac disease.
All right, Alvin, thank you so much for joining us today. I know you were one of the people who took care of this patient back in your fellowship, so we're really excited to just learn more and hear more about your experience with her.
Great. Well, thanks for having me.
Our pleasure. And as Jennifer and Ozzy outlined, celiac is something we definitely think of as kind of bread and butter pediatrics. I know there are kind of some common signs, symptoms, things we think about when someone comes in with celiac disease. Can you tell us a little bit about maybe a common age or common cluster of signs when that diagnosis is first made?
Yeah. So Megan, celiac is actually very common. So I'd say about 1 out of every 100 kids will end up being diagnosed with celiac disease. And symptoms can start pretty early. They can start as early as 8 months, 12 months as they start ingesting a little bit more gluten. And we really start seeing a peak when they turn about 2 years old. So kind of similar to what we saw, at least in this patient. Classic symptoms would be your gastrointestinal. So classic things would be stomach pain, vomiting, nausea, diarrhea, sometimes even some constipation and very poor growth. But I think one thing is celiac is one of these great mimickers. It can really present with anything. You can get anemia in isolation, you can get skin issues, and as we just heard, you can get neurologic symptoms as well. And on the flip side of the spectrum, perhaps the most common, it's actually the symptoms can actually be very mild. Many patients are actually asymptomatic, and when we look at some of the studies, about 70% of patients who have celiac disease are actually undiagnosed. And I think this really speaks towards how varied the presentation is and why sometimes it's really challenging to make this kind of diagnosis.
Yeah, definitely. And we heard about these kind of vague GI symptoms at the very beginning of her disease onset, that brief AGE, but our patient had such striking neurologic manifestations, and it seems like those were in some ways her only manifestations. Is that typical for kids her age? Is that something we should always think about?
Yeah, great question. So for kids, it's rare. So if you look at the literature for teens and adults, the neurosymptoms are pretty common. Headaches, they talk about. It can be irritable. They can be fatigued, depression. In rare cases, it's also seizures. And I think for when you think of the adults and teens, it's commonly that brain fog that people talk about. But for kids, it's actually much more rare. And especially to present with developmental regression, that's extremely rare. And that's part of the reason why we wanted to write up this case. And I think even before us, there's probably been a couple cases, but really to show with normal development and then they suddenly start regressing, that's pretty rare. I think the next question is, why do people have these neurosymptoms? Hard to say. I don't think people fully know. Part of it is we know that there's autoantibodies that's floating around, and the thought is that these autoantibodies can float around, they can pass the blood-brain barrier, and they can affect different parts of the brain. So that's the hypothesis is why we can get such striking neurologic symptoms.
That makes sense. And it's so good for us to know. I tend to think of celiac as really living in that GI region. And like you said, it is the great mimicker, but I don't tend to think of it moving out of the GI tract.
Yeah.
So always good for us to be aware that other systems can still end up having a root in the GI tract.
Yeah, absolutely.
I want to shift gears a little bit and talk about diagnosis. So this patient had serologies done, and then she also ended up having a biopsy, which was really how the diagnosis was definitively made. I understand there are some new recommendations for diagnosing kids her age. Can you tell us a little bit more about that?
So at least here in the US, the gold standard is still the biopsy. But back about a couple of years ago, back in 2020, our European colleagues actually published these new guidelines. And these new guidelines actually is a no biopsy approach. So what they do instead is the main criteria is they're going to do an antibody testing. And this one's going to be your transglutaminase IgA. So your TTG, IgA, if it exceeds 10 times upper limits of normal, with a separate test later showing positive endomysial antibodies, then you can make the diagnosis. And that kind of got rid of the whole idea with the biopsies, the HLA genetic testing, that's kind of gone away. And you actually don't even need to have symptoms to make the diagnosis of celiac disease. And that's kind of been a game changer here. And I would say it hasn't fully picked up for all cases, but there are certainly select cases in which we would rely only on serologies. But I think especially as we talk about kids and pediatrics, to commit someone to a lifelong diagnosis and treatment, we'll always have the conversations with families, and then we'll do the biopsy based off of how that conversation goes.
That makes a lot of sense. And I'm sure there are many relieved parents, hopefully when these guidelines kind of become more popular in the US, who are very glad to not have to put their child through sedation and the kind of trauma of a scope. So it's great we're heading that direction.
Yeah.
Mentioning antibodies, I never want to order the wrong thing. So when I'm scared, I have a patient with celiac disease in my office. I'm like, let's just order everything. I love the celiac panel. Is that something that I should be ordering, or is that overkill?
Yeah, so that comes up often. I think if there's only one test, and people have done a lot of studies on sensitivity, specificity, cost effectiveness. If there's one test, Megan, you should just now know, is TTG. So this is a tissue transglutaminase, and this is an autoantibody that gets developed due to an abnormal immune response and ends up attacking back to TTG within the intestine. And people have looked at this is the single most important test. And if you look back on some of the older guidelines, they do talk about that, maybe if they're under 2, you need to check other types of tests. But I think now the evidence is pretty strong, TTG along with the total IgA level, because we do know that there is about 10% of the times you can be IgA deficient if you have celiac disease. So the very first time would be TTG IgA as well as IgA total level.
Okay, so even though the celiac panel is calling my name in Epic, I should not click on it.
TTG, that's it, make it simple.
TTG only. And IgA.
And IgA. So
perfect.
The next question can be, if they are IgA deficient, what do you do? So, okay, so now the second test, the other one that you do need to remember is this DGP IgA. So this is a deaminated gliadin peptide. So for those, the 10% that are IgA deficient, you'll get the DGP IgG. So many letters.
At that point, I am either on UpToDate or calling you. Perfect. And then we have this kind of group of patients who, let's say they come in with symptoms that really sound like celiac disease. We order the correct diagnostic tests and everything comes back negative, but they tell us, hey, I really feel strongly that when I don't eat gluten and I avoid wheat, I just feel a lot better. What do you say to people like that? Or kind of how do you advise pediatricians who are dealing with patients like that?
Yeah, I believe them. I think I would believe them. In LA, there are a lot of people who might, go gluten-free, but I think that for this specific type of population who swears that they take out gluten and they feel better and they're negative on the celiac testing, I do believe that when they take out wheat products, they'll feel better. And I think the culprit is not so much the gluten, it's actually going to be some of those fermentable carbohydrates called FODMAPs. So FODMAPs, it's fermentable oligo monosaccharides and polyols. So these FODMAPs, and these are fermentable carbs that's very common in wheat products. And I think that's really the reason why some of these select patients are getting the bloating and the pain and some of the looser stools is because of their reaction, their intolerance to these FODMAPs. So classically, these patients are known as gluten, non-celiac gluten sensitive, but personally, I think that these are more patients who are just particularly susceptible to the FODMAPs. That's very common in foods like wheat and amongst other things.
Okay. Oh, that's good to know. Mm-hmm. And sort of veering now back to the traditional celiac disease diagnosis, once we confirm the diagnosis and we have a reason to tell the family their child is symptomatic, what's the next step in terms of treatment? Ozzy and Jennifer kind of briefly touched on it, but what do we tell families their life is going to look like next?
Yeah. Right now, the only and the best treatment we do have is a gluten-free diet. And certainly, I think it can shake a family, it can rock the world. It's cumbersome. But I do try to put a positive spin to it because of all the disorders to have, a chronic disorder, I think celiac disease is probably one of the better ones because this is one where we actually have a cure. It's a gluten-free diet. There's no minimal side effects. There's no medications involved. So I try to make this on a positive spin.
And that makes sense too, pointing out, hey, it's a struggle getting this kind of lifelong diagnosis, but we don't have to worry, like you said, about medication reactions or filling prescriptions, and with some lifestyle tweaks can be really well managed.
Right.
That being said, I know families very understandably struggle with this kind of new lifestyle they're oftentimes thrust into with very little notice. One of the things I hear families ask a lot is, hey, while we're learning how to cook gluten-free meals or prepare gluten-free meals or find gluten-free food if we don't like to cook, should our whole family be eating gluten-free? How do you typically advise parents in those situations?
Yeah, this is a tricky one because I think on one side, you see that if you turn everyone gluten-free, meal prep is probably going to be easier. The risk of cross-contamination is much lower. You won't have these unsafe foods. But on the flip side, especially if there's other people in the house, it's going to be really unfair for, the 6-year-old brother who now has to eat everything gluten-free. And I can see that really putting a strain on the families. I think that maybe there's a middle ground in some of this, and at least from what I've heard from families, one option can be gluten-free at home, and then when they go out to restaurants, they can do whatever they want. The other options is you can choose specific dates to be gluten-free, and then for some of the staple products that might have gluten, such as some sauces, some condiments, those things you can go all gluten-free. So maybe somewhere in the middle ground, but it's really going to be really family dependent on what they feel most comfortable with.
That makes sense. And I'm glad you brought up the things like the condiments and the sauces and the seasonings, because I think everyone automatically knows about bread and pasta and kind of the traditional wheat products, but we don't realize that things like soy sauce or a lot of salad dressings can have gluten. So making sure to warn families about things like that.
Right.
And it makes sense that you just consistently want those things to be safe for the gluten-free child in the house.
Yeah.
By default, everyone else. And once the family kind of has a routine set up at home, another sticking point I've heard a lot about is social events where food is a really big thing. Things like birthday parties. How do you typically recommend parents handle situations like that?
Yeah, this is a good one. This one actually just happened to me. I have a school-age kid. We were hosting his birthday party. One of his friends had celiac disease, and what this very astute family did was they actually just called us beforehand and said, hey, are you going to be offering any type of gluten-free products? Will there be cake, and do I need to bring anything else? So I think the first one is, if you're worried about going to birthday parties, you can always just call the other family to see what's being served and what's not. Some other options is you can always bring with your child the gluten-free cupcakes, at least when everyone's having cake, that they have something to eat too. And I think the biggest one is probably just, I would try not to bring your kid to the party hangry. So feed them a little bit before, give them their, gluten-free item, and then you can send them off to the birthday party.
Always good life advice for any situation, no matter what. And speaking of hangry children, another lovely age range, the teenagers.
Yes.
So I've heard of teenagers who have been pretty adherent, but then have a little more independence, become a little bit more aware of the situation, realize, hey, I feel pretty good, and decide to self-discontinue the gluten-free diet, but will come into the office and say, I don't think I need to go back on my gluten-free diet because I still feel okay. How do you handle that situation?
Yeah, this one's tricky. So luckily my boy isn't a teenager yet. So I think for the teenagers, I think part of it is going to be really challenging them and asking them what is feeling okay, because you could be consuming little bits of gluten, but you might not be at your optimal self. The other part that I try to emphasize would be, you might not reach your growth potential, and you try to connect with them. If they're doing sports or playing basketball, then you might say, maybe if you go gluten-free, you might just feel a little bit better. You might get a little bit stronger by going gluten-free if you're interested in basketball. I don't try to use the argument of, cancer risk and fertility even. Sometimes that's challenging for some of the teenagers since they can't really look that far into the future, depending on their age. But I try to connect that with them, at least on the short term, that, hey, by doing this, it might, optimize your school performance, it might optimize your sports.
Smart. And while we're figuring out sort of how adherent a patient has been, or while we just want to see how they're doing with their celiac disease, is there long-term monitoring we should be doing?
Yeah. So when we first make the diagnosis, first thing I do, I set them up with their dietitian. They'll go over everything that has gluten, different options that they can try. They'll introduce them to certain resources and apps to find restaurants that might be gluten-free. And then as far as follow-up goes, we usually follow up in about 6 months. And at that 6-month follow-up, we'll see how they're doing with the diet, how their growth is going, any struggles that they're seeing. And then we'll usually do the first set of repeat TTG labs just to see how the numbers are going. You should expect by 6 months that the TTGs to start coming down. When they should normalize, it kind of depends. For some families, or for some patients, it can be several months, but we've seen as far as a year or so even, or even longer for the TTGs to come down. So once they are finally normal, then we just can do yearly TTG labs.
Awesome. And is this something, if the pediatrician feels comfortable doing, that they should be doing themselves, or should we be sending every single patient to GI for this sort of monitoring?
Yeah, I think at least in the beginning, once we make the diagnosis, we'll like to keep them close, make sure that they're on the right track. But really, I think that once the antibodies have fully normalized, I think the pediatricians can fully do all the follow-ups. And in case there's something odd happens, the TTG comes back up, or now there's recurrent breakthrough symptoms, despite normal TGGs, then we'll always be happy to see the patients again.
That makes sense. We like to keep the referral pipeline open and not clog it up too much when we can avoid it. Last question, and again, we're so grateful for your time.
Of course.
Any new treatments on the horizon that you're excited about? Anything we should expect coming soon?
Yeah. So at least for now, the only treatment is the gluten-free diet, but in the pipeline, there is actually many different types of drugs. And many of these drugs kind of target different parts of the pathophysiology, the different parts of the pathway. So they're working on enzymes. So these enzymes, what they do is that they're going to enhance the digestion of some of these gluten peptides that's going to happen in the stomach, such that they'll all break down in the stomach. So by the time it reaches the intestine, it won't be as antigenic. There's other ones, TTG inhibitors. So what that means is the TTG, one of its main roles is this deamidates some of these gluten peptides. And that's ultimately what causes the abnormal immune response. So there's TTG inhibitors that prevents that deamidation process such that the immune response to these gluten peptides would be a lot lower. Other ones would be, there are these medications that they're working on to try to improve the tight junctions. So just thinking that celiac disease, leaky gut, and some of these gluten peptides kind of permeating through the gut. So there's some medications that will prevent some of that leaky gut. I think those are the pipelines. The way I see this right now is I think that the gluten-free diet will almost always still be the primary mode of treatment, but these medications might be used as a supplement, as adjunct. So you're thinking about, when we take for a patient who might have lactose intolerance and taking a lactate, they might just want to take that before they, want to go and have a gluten-full cake or something.
Okay. I mean, cheat days are still important, right?
Absolutely.
Well, thank you so much for your time and your expertise. We're so grateful.
Great. Well, thank you so much, everyone.
All right. Thank you guys so much. That was really, really interesting and fascinating. And I just have to say props to you for figuring out FODMAPs on the fly there. That's not an easy acronym. Thank you, Chiefs. Thank you, Alvin. And great job, you guys.